also from Dr. Ding's book, the 70-year-old male with back stool and abdominal pain. And my anemia, leukocytosis, and then from our endoscopy, they find 5 to 6 centimeter mass. Then they do this biopsy of this mass, show infiltration of small lymphoid cells, and then positive for B cell marker CD20 and CD79, but negative for this kind of marker. We know not CD5, that means not CILS, CLL, cyclin D1, not mantle cells. So then what is our differential diagnosis? Of course, is always thinking of reactive and then a mature B cell neoplasm. So what further tests we should order for the diagnosis? And then here's a really important test for that. That is our clonal proliferation. As this patient is positive for immunoglobulin heavy change and light chain kappa. So the diagnosis is the mock lymphoma. But when we do the fish transfusion, we could not detect this 11-18 transfusion. So let's talk about this colonoscopy test. So we know in heavy chain, we have this VDJ rearrangement, and then light chain, we have VJ rearrangement. And then the major concept of clonal test, that means we have kind of most of the reactive process, we will have different kind of this rearrangement. So that means when we use PCR, multiplex PCR to amplify this product, we have multiple band. We could not see like a single really bright band. If we detect that band, that means we have clonal proliferation. So just a supportive test to tell us whether this is a malignancy. So right now we use the multiplex PCR-based colonoscopy test. That's what is the limitation of this test. So as we know, we have this pseudo colonoscopy or even false negative. So both false positive or false negative results. So we really need to have some concepts of why we have this kind of results. One of the important things is that if we have low number of B cell in our slide, so and then we will have this background signal. So we will have a false positive or false negative result. So what we can do to increase this sensitivity and specificity, we can just circle the area we want to have this clonal test. And then also we need to bear in mind that a positive clonal rearrangement is just supportive, because even in some kind of infection like maybe like Lyme disease or any other infection, they may also have this clonal proliferation, because we know our B cell want to mature into plasma cell, and then they have this antibody to attack this bacteria or any other thing. So maybe they just find one clone, they can have really effective antibodies. So as a human being, we will have more of that clone. So sometimes even in reactive condition, we will have this positive colonoscopy test. Then I know when we rotate in surgical path and also our bone marrow surface, we will order like this in situ hybridization of kappa and lambda light change. So this topic is just tell you this kind of hybridization method is not as sensitive or specificity as our molecular test for this colonoscopy, because all of these like follicular cell lymphoma, DLBCL, mantle cell, they have low level of light chain message RNA. So there's cannot use this method to replace of this colonoscopy test. So the further workup of this patient, when you diagnose a lymphoma, we always want to know whether this patient get bone marrow involvement. So we do bone marrow biopsy. Then the flow show a different immunophenotype, different than the first one. So we have CD19, CD20, CD5, right now CD5 positive, and then CD23 also positive, and then have dim kappa light chain restriction. So this immunophenotype is consistent with CLL, but it did not meet the criteria for CLL either. We need to have more monoclonal B cell in the blood, and also this patient do not have like symptom or adenopathy. So that kind of so we need for the test because we know this patient had most lymphoma, but in the marrow we could not find most lymphoma, but we can find another restriction light chain kappa chain clone in the marrow. So we want to know what's going on. So and then we do this compare this clonicity test in using the same patient sample but from two different locations. So we can see both of these two tests, we can show this really bright band. So we can see this is all other control, monoclonal control. We just see just something like beer. We do not see really bright band. This is 10% sensitivity control. We can still see this beer, and then we can see a little bit bright band. And then our hair cell do not have this band. So we have this really bright band using two primer from the immunoglobulin heavy chain. Then we have this light chain kappa. We also can see this bright band, but it looks like a little bit different. So what's going on with this patient? So we run our NGS test. We find that in bone marrow, in this heavy change, we have this 302 base pair sequence. Then in our in the bone marrow sample, we have one band immunoheavy change. And then in multiple lymphoma sample, we have another band immunoheavy change. And really interesting, another small clone is just identical, both in multiple lymphoma and this marrow. So what does that mean? That means this patient have two disease, and each of the disease is true. They also have this monoclonal process. So our diagnosis finding for this one is gastric lymphoma with double marrow involvement. And then the bone marrow finding just this monoclonal B cell lymphocytosis. So I think that's it for this talk. Any question?